what's going on with the picture of Chile. You see here that's Chilean landscape photos.
I thought it was an image of your hospital.
Excuse me?
You had an image of your hospital before.
Yeah. We're ready? Yep. Hello. Good afternoon. I'm Marcelo Galvez, CLC neuroradiologist, a member of the Advanced Epilepsy Center. Welcome you to this 2021 series, Topics in Epilepsy, Talking with Expert. Organized with the CLC Advanced Epilepsy Center, I'm to offer opportunity to share with prominent specialists in the field. Today's speaker is Dr. William Eiler, Professor of Pediatrics and Neurology at George Washington University, Professor of Neurology of George Washington University, Chief of the Division of Child Neurology, Epilepsy, and Neurophysiology, Director of the Comprehensive Epilepsy Program in Children's National Medical Center in Washington, D.C., Past President of the American Epilepsy Society, who is here today with us from Washington. We cordially invite you to make all your questions in the Q&A box you can see in the top right corner, which will be directly transmitted to the moderator. This instant will be led both for Felipe and me. Dr. Gaia, the floor is over you.
Okay. Thank you very much for your kind introduction. I think I've got my screen up now.
Yep.
Is that working?
Yeah. You can put in a full screen?
Yeah, I can't, I've lost the ability to do that. Hold on. Does that work?
Yeah, great.
Yes, exactly.
Okay. So again, thank you everybody for the very kind invitation and opportunity to speak to you today. I hope that one day we can all meet in person, either in my home country or in your wonderful city. So today I will be speaking about how neuroimaging has enhanced our care of early onset epilepsies. And it is customary to begin with disclosures. I normally thank people for paying taxes to support my grant work, but that doesn't happen for Chile. As an officer of AES, I have imputed conflict of interest with all pharmaceutical industries, and I use pens and flashlights with logos. I don't know if that's a restriction for you. So I will be talking today about epilepsy and imaging. I will spend most of this talk talking about imaging for the evaluation and treatment of children being considered for epilepsy surgery. But of course, imaging is more than just epilepsy surgery. So imaging is pursued to establish an etiology, which you can achieve in about 1/4 of patients. Knowing that etiology and imaging findings can provide prognostic information. It also guides evaluation and may direct therapy. And these are really important matters. In terms of surgical patients, early surgery is better for outcomes and seizure control. In so doing, epilepsy imaging helps identify potential candidates who may benefit from surgery. It helps confirm the focus, which is really critical for epilepsy surgery, and functional imaging can be used to identify areas to be spared during epilepsy surgery, and that can be cortical or it can be white matter critical cortex. Who should be imaged? Well, really anyone with a focal epilepsy, and because you're more likely to find focal imaging abnormalities in that population. And that really means any child less than 3, because the primary generalized epilepsies are very rare in this population, and nearly all children under the age of 3 will have, should be imaged. So below is the epidemiology chart demonstrating the large number of children who will experience onset of epilepsy before their 3rd year of life. It is optimal to obtain that imaging at seizure onset. However, there are places and circumstances where resources are limited. And in that setting, quality imaging is reserved for when medications fail the child or there is clear clinical deterioration, in which case imaging should be pursued. It is important to recall that you may have a nice scanner, but really there is nothing that equals a skill in pediatric imaging and interpretation, and also in pediatric anesthesia to get images in young children. The other item and the main factor of this talk is that more than any other group, imaging and interpretation and imaging in this group must be conducted in the setting of understanding brain maturation and development. So we're going to talk a little bit about imaging in developmental context, and that's because brain structure and brain function changes with age. There are global changes with age, there are regional changes with age, and there is longitudinal maturation. So some of the items that change with age are brain volumes, the whole brain, gray matter, white matter, and lobes. There is a change in cortical thickness of the gray matter, and that reflects changes in synaptic density and synaptic pruning, which is part of brain maturation. White matter myelination, the brain is less well myelinated before the age of 2, but myelination continues until the mid-20s, which is why, at least in my country, the insurance rates for auto insurance change at 25 when the frontal lobes become fully myelinated. There are anatomic correlations of this, which I think are obvious, but there are also functional correlates in terms of blood flow and cerebral metabolism studies looking at glucose consumption. So I will go through some examples of these items. On your right are the very elegant studies of Peter Huttenlocher showing regional variation in synaptic density, which occurs in the first few years of life, and then how synaptic density is pruned as the brain matures. And on the left are the elegant studies of Yakovlev, who looked at the myelination of specific fiber tracts in the brain across development. These, of course, can be done now with imaging. And this is a study showing that the volume of gray matter and white matter change with age, and that there is a regional trajectory of brain volumes across age. And you can see some, as the cerebellum continue to expand, and those in the association cortices tend to diminish after the age of 10. This is the very elegant work of Jay Geed when he was at NIH. And this is showing people after the age of 5 to 20, showing that there is a change in the cortical ribbon thickness that is regionally dependent and age dependent across time. This reflects synaptic pruning and maturation of cortical circuits. There, of course, is a metabolic correlate to these findings. So this is data from Catherine Chiron looking at blood flow, and Harry Chigani looking at glucose metabolism using PET. And there is an increase in uptake in blood flow and in glucose consumption after the age of 2, reflecting a burst of synaptic development. And then after the age of 9 or 10, those decrease as synaptic pruning occurs, because these are measures predominantly of synaptic activity. So these are the functional correlates of synaptic generation and pruning that you see in the evolution of cortical thickness. And these are the maps of the maturation in several white matter tracts, looking at fractional anisotropy in those who are older, and on the left, those who are younger. So the fiber tracts that connect different brain regions have their own pattern of trajectory of maturation. When looking at imaging studies, especially in those who are infants, it is important to recall that there are imaging correlates of maturation of gray matter and white matter, and those are reflected in T1 and T2 images. Myelination occurs medially to laterally, and it occurs caudally to rostrally. You can see the changes in the distinction between the gray-white junction in these images across infancy. I will now turn to specific imaging modalities and their use. I believe that CT has a limited or no role really in epilepsy surgery, and it has a very limited role in evaluating someone with new onset epilepsy. CT confers radiation. It has low resolution. It misses significant pathology. And as a consequence, it may be falsely reassuring. It is best used in an acute setting where there is concern for an ongoing intracranial process, such as a bleeding and gross abnormalities. So it picks up blood and it picks up calcium associated with, for example, congenital infections. The imaging modality of choice is a high-resolution structural MRI using an epilepsy protocol, and that should be viewed as standard of care. That is for evaluating children with epilepsy. For surgical evaluation, when MRI does not prove helpful, then FDG PET, SPECT, and functional mapping with fMRI can be pursued. So here is a CT scan showing a CNS hemorrhage with someone with acute seizures, and a CT scan of someone with toxoplasmosis with cerebral calcifications. And this is the last CT image that I will show. So we use MRI, and this is the MRI protocol that comes from the ILAE work, which has been updated by the Bernasconis just in the other year or two. So these are a high resolution 3D T1 image with less than 1 millimeter isotropic voxels. 0.75 millimeters can now be obtained. Best to acquire in the sagittal plane as easier to correct for motion. Axial and coronal T2, although you can now acquire these in 3D, and the same is true for FLAIR. You want at least 2 axes, and if you get a 3D acquisition, then you have all 3 axes to look at. One should still obtain an oblique coronal high resolution fast-spin echo sequence along the hippocampal formation. And for epilepsy, gadolinium contrast is not necessary unless there is a concern for a tumor or for an inflammatory process. Infants represent a special category because because T2 and FLAIR imaging is less useful. And in fact, T2 imaging is the most helpful sequence in those less than 2. So we still acquire 3D T1 and FLAIR cube, but they are less helpful than our T2 images. There are sequences that increase resolution and things you can do to increase resolution of the scanner you have. So 3 Tesla units are superior to 1.5 Tesla units, which are superior to 0.5 Tesla units. And 7 Tesla units are probably better yet, but they require great care and skill and MR physics to be able to utilize, and 7T remains uncommon. As I have mentioned, T2 sequences are better than T1 and FLAIR for infants. It's also important to have the appropriate slice thickness. The cortical ribbon is 2 millimeters, so you need to image less than 1 millimeter in order to get good visualization of the cortex. Otherwise, you will have volume averaging and miss significant pathology. You don't want to skip slices, and thicker images may miss focal lesions. There are some sequences that some investigators had advocated for which there is limited evidence. They may be helpful in particular settings, but not in all children. These include magnetization transfer, MR spectroscopy, susceptibility imaging, DTI, ASL, and so forth. So the data from the adults and children at the UK using the 3 Tesla scanner is remarkably similar to the data from a pediatric epilepsy research consortium imaging infants that is defined as anyone less than 36 months with new onset epilepsy. Almost all of these children had MR imaging. Some did not because of past imaging or contraindications to scanning or anesthesia. Almost all were imaged with an epilepsy protocol, and the majority, but not all, were imaged at 3 Tesla. Abnormalities were identified in nearly 40% of patients. Of all the patients imaged, findings relevant to the etiology and treatment were found in 23%, or roughly 1/4 of patients. So 1/4 of patients will have information that directly impacts the prognosis and care of that child. And of all the patients imaged, 10% had abnormalities that were potentially amenable to surgery. So these would be children that would be identified early on to be at high risk for refractory epilepsy so that surgery could be pursued earlier rather than later. So here are some images. The cause of epilepsy is established, and this may require further evaluation. For example, a search for genes in the child with lissencephaly may change management, as in the case of the patient with a tumor on the left. And of course, the child with adrenal leukodystrophy takes you down a completely different path of treatment. The prognosis for seizure control may be poor for some, and some will not be candidates for epilepsy surgery, but they will inform your discussions with family and subsequent treatment. Metabolic imaging helps direct evaluation and metabolic treatment. These are not patients for curative epilepsy surgery, but it certainly modifies how you approach the care of the child. This is a child with a lactate peak, cerebellar atrophy, and increased signal in the deep brainstem structures, indicative of a metabolic cytopathy. I will just pause briefly to mention that the relationship between MRI findings and genetic etiologies has been growing exponentially in the last several years. So while these may not be candidates for epilepsy surgery, the findings on the MRI may suggest genetic syndromes and a search for those genes. And at some point, knowing that gene may then lead to targeted gene therapy and personalized medicine. So what is most known are the disorders of the P13K AKT-mTOR pathway, which includes tuberous sclerosis, the renin tubulin pathways for lissencephaly, Zellweger's, Walker-Wahlberg, and so forth. And on your right are just a series of images of different genetic syndromes that have characteristic MRI findings. And on the left is a child with tuberous sclerosis. Okay, so as we have mentioned, when you're looking at structural MRI, infants require specific sequences, and this is important for the following reasons. The timing of imaging in children is critical because imaging focal cortical dysplasia may come and go depending on the age of the child. Here is an example of a child with neonatal focal seizures, and the imaging study performed at 7 days of age identified the focal cortical dysplasia, if you can see my arrow right here, and that dysplasia was not apparent at 2 years of age. So the most relevant imaging to determine the dysplasia in this child was conducted in the first week of life. So, and in the converse, if the imaging is normal, you want to repeat that imaging after the age of 24 months or earlier if need be. So here is an example. Here's another example of a child with polymicrogyria. It was evident at 3 months, and then with maturation and myelination at 11 months and changes in signal, it is very difficult to appreciate the polymicrogyria in this child. And here is the converse. So here is a child at 18 months with focal epilepsy whose MRI is completely unremarkable. Repeating at 4 years shows the glass ground appearance of the focal cortical dysplasia in the left temporal lobe seen over here, and you can also see on the coronal imaging. So repeat imaging in this child after myelination had progressed made it able to discern the dysplastic appearance in the left temporal lobe, and this child is a candidate for surgery with a higher outcome. So the dysplasia can either appear or disappear with age, depending on the child. Here's an example, somewhat unusual but fortuitous, of a child who's 2, whose imaging at T2 and T1 is unremarkable, but magnetization transfer imaging readily identifies the area of dysplasia in the left occipital-parietal cortex, which I think you can see here. Mesial temporal sclerosis is the most common pathologic substrate that is operated upon in adults for temporal lobe epilepsy. Mesial temporal sclerosis usually occurs in childhood and infancy, and this is just our images to demonstrate and to remind us that mesial temporal sclerosis can occur in infants. This is a series of 5 children that were found several years ago, usually in the setting of fever and febrile status. In the ILAE 2004 Pediatric Epilepsy Surgery Survey done by Simon Harvey, 40% of surgical patients had malformations of cortical development, and specifically focal cortical dysplasias. 1/5 had tumors, 1/10 had some form of stroke. Mesial temporal sclerosis is 7%, and that number is lower in current series. And then various pediatric entities such as tuberous sclerosis or hypothalamic hamartoma or Rasmussen's. But of the substrates upon which we operate, focal cortical dysplasias are the most common. And the hallmark features of focal cortical dysplasias are thickening of the cortical ribbon, blurring of the gray-white junction, and increased signal in this area. So this is a dysplasia, of Taylor, which you can see with the signal change. The other red circles show a bottom of the sulcus dysplasia with thickening of the cortical mantle and blurring of the gray-white junction and some enhancement in T2 signal. These are the hallmark features that we seek in reviewing MRIs. The other findings on your left, the tumors, the strokes, are not particularly subtle. There are mounting data that early surgery results in better outcomes. Many people have considered epilepsy surgery to be a treatment of last resort. In fact, for many children, it is the treatment of choice. So one should not delay in those considerations. The data on the left are from children with hemimegalencephaly. The data from Tokyo showing every month decline in hemispherectomy resulted in a proportionate decrease in long-term IQ and developmental quotient. And the data on the right come from the very large European consortium showing that later surgery is associated with a lower likelihood of achieving seizure freedom for different pathologic substrates. And this data has been confirmed by a consortium agreement across the world looking at focal cortical dysplasias. So if you identify a potentially operable lesion, it is important to be aggressive in considering timing of surgery. These are follow-up data from the 2004 survey. This is put together by Gary Mathan. The centers were re-polled in 2010, and the number of centers expanded. So this represents data from over 1,000 patients, mostly at a time when 1.5 Tesla scanners were used. And the point here is that if you had a clear lesion on MRI and you were able to resect that lesion, the likelihood of seizure freedom was about 85%. And if you did not completely resect that lesion, the likelihood of seizure freedom is about 15%. If the MRI was normal, then the likelihood of achieving seizure freedom is about 30%. And if you had a complete resection of something you couldn't see, the likelihood of outcome is about 44%, and incomplete resection is 3%. And what this really means is these are the patients in whom the MRI is normal, but in whom ancillary studies, such as FDG PET or ictal SPECT or source localization, either with EEG or MEG, found focal abnormalities that could then direct the surgical evaluation results in seizure freedom in approximately 50 to 60% of those patients. So if you are truly image negative, MRI is negative, PET is negative, SPECT is negative, MEG is negative, those are really poor candidates for epilepsy surgery, although it still may be the best option for rare children. So let us turn to PET, positron emission tomography. These are conducted intraictally. The ligand here is FDG. It measures the metabolic rate of glucose consumption. You are looking for regional hypometabolism that lateralizes the seizure focus and may localize the seizure focus, but that is less certain. The better narrowly demarcated the abnormality, the more likely that is to be localizing. Paradoxically, the epileptogenic zone is hypometabolic in between seizures, and that region of hypometabolism is more widespread than the epileptogenic zone. And it usually reflects either loss of neurons, dysplastic neurons, or altered function in some form. Focal cortical dysplasia typically is hypometabolic for the reasons above, but rarely it can be hypermetabolic, which I will discuss momentarily. So in children, FDG PET is abnormal in approximately 60% of children, including those with normal MRI. It may be particularly useful in those children less than 2, when the MRI is less sensitive to identifying abnormal brain, because even though you can't visualize the dysplasia, it is metabolically abnormal, and that can be visualized by PET. The greater the degree of hypometabolism, the better the outcome. Diffuse, remote, or bilateral PET abnormalities are associated with poor outcomes, and you can evaluate the integrity of the good hemisphere when considering a hemispherectomy. And I would say most importantly, when you conduct an ancillary study such as 3D source localization or ictal SPECT or FDG PET, when you find an abnormality, then when you re-review the MRI in light of that data, often you will find that the MRI is in fact abnormal. In so doing, you increase the likelihood of surgical success from 60% to 85%. And that is an important improvement in care. These are studies from that observation from the UCLA group. On the left are 2 PET scans co-registered with MRI. The MRIs were initially read as normal. The PET scans were abnormal where the arrows are. And when you re-look at the MRIs, you find lesions, which are dysplasias. And once you see them, they're obvious. But when you're looking at 1,000 images in one patient, they may be very easy to overlook. So again, the PET scan in these settings helped identify a dysplasia. The images on the right are areas of larger hypometabolism that correlated with a type 1 focal cortical dysplasia, but imaging remained normal in these children. So these are functional abnormalities. Here's an example of a child with a very narrowly focal hypometabolism in the tip of the left temporal lobe where my arrow is, and that corresponds to this very clearly demarcated focal cortical dysplasia in the left temporal lobe. This is a child whose MRI was interpreted as being normal. The PET scan is quite markedly it's abnormal because of the extensive hypometabolism in the left temporal lobe. You can see the left is hypometabolic relative to the right. And the 1.5 Tesla MRI was absolutely normal. But in re-reviewing the 3 Tesla scanners, many of you will see, in fact, in the right temporal lobe in the tip, there is an area of increased thickness of the cortical rim and blurring of the gray-white junction and increased signal on FLAIR imaging. This represents a temporal tip focal cortical dysplasia. And again, the hypometabolism is more widespread than the structural abnormality. Here is a child who had facilitated spasms and developmental delay. The spasms were successfully treated. The EEG remained remarkably abnormal over the right hemisphere, and repeated imaging with MRI was normal. FDG PET conducted serially demonstrated right hemispheric hypometabolism on the 2 or 3 studies he had. And finally, at the age of 17 months, one could finally see the diffuse white matter abnormalities involving the entire right hemisphere. This child remained seizure-free after hemispherectomy and made significant developmental gains and milestones after the hemispherectomy was performed. He was effectively in an electrical status that was non-clinical. If you look at large series of pediatric FDG PET studies, there are some children who have, rather than hypometabolism, have an area of regional hypermetabolism. And these are images from the Miami group. So this is increased uptake in glucose. These are bright signals. And in each of these circumstances, this increased uptake in FDG is linked to a focal cortical dysplasia or malformation of cortical development. And when these areas were studied with intraoperative monitoring, they were found to be effectively in electrical status. So when you see regional hypermetabolism, this usually reflects an underlying brain abnormality that is very electrographically and electrically active, even though you may not see clinical manifestations of that. And I should add, the abnormalities were not that subtle on imaging. Children with tuberous sclerosis are a particular challenge because the multiple tubers are apparent on MRI, but the tubers are hypometabolic. So FDG PET shown here in image B shows many tubers which are hypometabolic, but does not help direct you to the tuber which is generating the seizures. And a ligand called alpha-methyltryptophan, which is a precursor of serotonin and excitatory neurotransmitters, has increased uptake in the tubers which are epileptogenic. And you find that in approximately 1/3 of patients with tuberous sclerosis being considered for epilepsy surgery. That's shown in the arrow in C, and this corresponds to the grid study that was done on this child. There is more recent evidence that there are different MRI signatures to the different tubers, and that the type C tubers shown here are more likely to be epileptogenic than the other tubers. And if this is substantiated by these 2 observations, that may be helpful in planning surgery for these particularly challenging children. So infantile spasms. So children with facilitated spasms often have abnormal eye. And that was initially found in the early FDG PET observations. They were done in children with obvious MRI abnormalities and had hypometabolism, in which case the FDG PET does not really confer additional information. But a minority of children will have a normal MRI. These PET scans may be abnormal, but PET scans in children with infantile spasms may not be stable. So it's important to repeat PET imaging in infantile spasms because of fluctuating findings. And finding an interictal study is problematic. But if you find consistent PET abnormalities, they become relevant and help direct treatment. So here are some examples. So those on the far left, on the upper left-hand corner, who have a clear focal abnormality, which is about 1/5 of patients with a history of spasms, will be candidates for epilepsy surgery because they have an area of focal hypometabolism. Those people with diffuse findings tend to have other metabolic or degenerative diseases, and they are not good candidates for surgery. And those with multifocal generally are not good candidates for surgery. But as the experience with tuberous sclerosis has shown, some of these children may still benefit from thoughtful, targeted surgery. The patterns on the right are the diffuse patterns of cortical hypometabolism, and these are children with diffuse extensive bilateral disease, and they are not candidates for focal resection to cure epilepsy. They may be candidates for palliative procedures. The next study is SPECT. This can use HMPAO or ECD. They are technetium ligands, and they are measures of blood flow. They have a half-life of 6 hours, which means you have a lot of time to image people after you inject them with the ligand. You cannot quantify them as you can with PET, and you need really to do an EEG for these studies. Interictal SPECT studies are unreliable because they are falsely lateralizing 10% of the time. FDG PET is very, very rarely falsely lateralizing. Ictal SPECT, however, is superior to interictal SPECT, and better yet is subtracting an interictal SPECT from an ictal SPECT. So that's called a subtraction study, co-registering that with the MRI, and you can use semi-quantitative measures, including VBM-based methods. These are helpful studies that have the same utility as PET in about 60 to 65% of patients. Their reliability depends entirely on the timing of the injection in relation to seizure onset. Because later injection means you may be imaging propagation effects, and that may lead to false localization or worse, false lateralization from propagation effects. It is a particular challenge to get ictal studies when the seizures are brief or when they are frequent, because then it's difficult to obtain an interictal study. But if you can get the ligand in shortly after seizure onset and certainly within 30 seconds of seizure cessation, this is what you get. So on the left is an interictal study, and in the middle is an ictal study, and they were both considered to be not particularly remarkable. But when you subtract the interictal study from the ictal study, you get an area of residual which shows a very clear area of increased perfusion in the right mesial frontal lobe, and that corresponds to this child dysplasia, and this child became seizure-free when this area was resectioned. There are relatively few published studies of SPECT in infants, but this is one of them. So this is a child with increased perfusion during a seizure in the left occipital lobe, which was confirmed by invasive mapping. Of course, one can now use an MRI scanner to tag water molecules as they flow through the carotid artery. And this is arterial spin labeling imaging that is a measure of blood flow. I find that the hypoperfusion is not very helpful, but when you have clear hyperperfusion in an area, that usually represents an area of ongoing abnormal brain activity and electrical activity. And these are just some examples of children, actual neonates, who had abnormal ASL imaging who were found to be in status and have corresponding focal cortical dysplasias. So you can see the dysplasia here on the MRI matching this area of hyperperfusion. So ictal ASL may have a role if you are so lucky to obtain. So comparing PET and SPECT, it depends on the methods and the experience and the analysis used. I think it's best to use what you are most comfortable and skilled with, because then you will be good at it. Both PET and SPECT, as well as MEG, which I have not discussed, generally show similar results. They have a similar sensitivity, a similar specificity, and that is similar to what you find with MEG. They both have advantages and they both have limitations, and they are often complementary, but they can also be redundant. So PET may be superior for temporal lobe epilepsy. Ictal SPECT is superior for extratemporal lobe epilepsy. Ictal SPECT tends to be a little bit better at localization rather than lateralization. The value of concordance is debated. It's not clear if doing both is necessary if one is abnormal. And quite frankly, neither adds much, if anything, when the MRI and the EEG are clearly abnormal and localizing. It does not confer additional information that changes your management. I am an fMRI person. I spend my life mapping out language and memory and other cognitive networks in patients with epilepsy to plan epilepsy surgery. That is not the topic of this talk. The children on whom we operate often have epilepsy onset during infancy, so it becomes relevant for that. And because of that, language systems can move. So in the lower left-hand corner is a map of different language tasks showing activation in left Broca's and left Wernicke's, showing this patient is left hemisphere dominant for language, which means one is free to operate on the right temporal lobe to cure this person of their epilepsy without risk to language. If you wish to identify eloquent cortex on an infant, one can do functional MRI. These are passive tasks. So auditory tasks give you bilateral auditory cortex activation, and you can do passive movement of the hand to demonstrate and identify the motor strip as shown in the lower right-hand corner. You do these in the sedated state. It must be light sedation, and you can titrate propofol to achieve this effect. Anesthesia will obliterate the bold response, and you will not get this finding. Therefore, you need to use lighter sedation. And please recall, these patients are unmonitored. And in the very, very young, you often get a paradoxical bold response, which is the topic of another talk. So this is getting us to the end of the talk. So what we do now is multimodal imaging. We combine all these data together. So here is a child with an area of hypometabolism on the PET that corresponds to this focal cortical dysplasia, which happens to be in the left superior temporal lobe, and that means we are at risk for language. So the functional MRI of language shows that the receptive language cortex is anterior and inferior to this abnormality. And when we do diffusion tensor imaging tractography, we identify the arcuate fasciculus as going right underneath this abnormality. So it is safe to remove the lesion without risk to language, but one cannot go too deep, as one will then impair eloquent white matter tracts that convey language function from the temporal to the frontal lobes. But that can be done successfully, as it was in this child. There are some findings that give pause for thought. So we have presented children at epilepsy conference in whom we felt had focal epilepsy. They had normal MRIs, and this child had the most strikingly abnormal PET scan I have ever seen in my life. You can see the profound hypometabolism in the right temporal lobe that affects the entire hemisphere. This child has an SCN8, this child had an SCN2A mutation. This child has a genetic epilepsy. This child is not a candidate for resective surgery. If this child had MTS or dysplasia, then surgery might help. But in the absence of a structural abnormality, surgery is contraindicated in this child. So we've had 9 children that we've considered for surgery that upon reflection turned out to have specific channelopathies and were not candidates for surgery. So for me, any child with a normal MRI, regardless of other findings, gets genetic testing before they go to surgery. In conclusion, imaging provides diagnosis, prognosis, and surgical selection. One must consider the image findings in light of brain maturation. Early surgery is associated with better outcomes and is related to image findings. A high-resolution epilepsy MRI at high magnetic field with pediatric expertise is the most important imaging tool for any child with epilepsy. Different sequences, for example, T2 images are best for children less than 2 years of age. Employ FDG PET or ICDL SPECT when there's a normal MRI or when the child is less than 2. And always respect the second look effect, because any findings from evaluation may allow you to re-review previous data and find an abnormality that has escaped your notice but will significantly change the prospects for that child. One can use fMRI sedation protocols for the very young if you are so inclined. Properly selected patients with bilateral focal abnormalities or genetic disorders with clear focal abnormalities still may benefit from surgery that may be palliative or that may be a cure. But when the MRI is negative, and certainly when one is image negative, one should very strongly consider genetic and inflammatory causes for the child's epilepsy, as surgery is less likely to be curative, and these findings may help direct therapy that may be beneficial to the child. So with that, I would like to offer you this maze of recalculation and thank you very much for your kind attention. And I'm happy to answer or do my best to answer any questions you may have for me.
We truly thank you to Dr. Galar for the great presentation. We will now proceed to the two cases represented by Dr. Francisca Lopez, the CLC epileptologist, and Dr. David Ladon de Guevara is the director of the Nuclear Medicine Imaging Unit. Remember that put your question on the chat. Felipe.
Bien. Bueno, agradecemos al doctor Aguilar por su brillante y muy completa presentación. Ahora procederemos a la sección de los casos clínicos, los que se han presentado por la doctora Francisca López, epileptóloga del Centro Avanzado de Epilepsia de Clínica Las Condes, y posteriormente las imágenes que serán discutidas por el doctor David Ladon de Guevara, el jefe de la unidad de PET-CT del Departamento de Radiología de Clínica Las Condes. Los animamos a que pongan sus preguntas a través del bot de Questions and Answers.
I hope the presentation is in Spanish.
How is your Spanish?
It has been translated for you.
I hope the slides are in Spanish.
Ya, comienzo entonces.
Ah.
Estamos boca.
Ah.
Sí. Bueno, buenos días entonces. Gracias Felipe por tu presentación y muchas gracias doctor Gayer por su excelente presentación. Voy a presentar brevemente dos casos. Josefa, she's a girl, 19 years old, with newborn onset epilepsy, with left body focal motor seizures, etiology, diffuse temporoparietal occipital malformation of cortical development, comorbidities, mild intellectual disability, or mild to moderate, and morbid obesity. About her epilepsy history, right focal motor seizures once a month. In 2019, she has a right body focal motor epileptical status, phenytoin responsive. And about current seizures, nystagmus with right versive head, right upper limb clonic movement above 15-20 per day, right versive seizures, right body tonic posturing on awakening. Previous treatment, lot of anti-medication drugs, and actually she's receiving more than 5 drugs. About EEG, in 2004, left parietotemporal occipital interictal epileptiform activity. 2 years later, the same, left parietotemporal occipital interictal epileptiform activity with focal slowing with normal background activity. And she has a pre-surgical video ED long-term monitoring on March 2019 with continuous left hemispheric slowing, left hemispheric interictal epileptiform activity, and generalized interictal epileptiform activity with max frontal. She has about 56 epileptic seizures arising from left occipital, 50 of them electrographic, and 6 electroclinical, with horizontal nystagmus, apnea, generalized hypertonia. And this is one of that seizures with a clear train over posterior areas. So what about pre-surgical discussion? She could be a candidate to epilepsy surgery with diffuse left cortical development malformation. We received this patient, I need to know to say this, when she was 17 years old, before she was treated in other places. So continue with the idea, diffuse left cortical development malformation, no M1 primary motor area involvement in MRI, 19 years old girl, no hemiparesis, and with 2 requesting about parents. Parent requesting to avoid motor sequela and visual field sequela. And because of cognitive impairment, was not possible subdural EEG study. So as stereotypized seizures and ictal EEG starting from left occipital, we decided to study with PET-CT in order to analyze the metabolic status of that lesion and try to focalize epileptogenic zone. So, Dr. Marcelo, could you?
Yeah, no problem. We have axial imaging. This is the first one. This axial. An axial image, you see an hypodense lesion in the left occipital lobe. In the other, in T1 and in 4 and in T2, you can see this lesion is not only subcortical. This is a low signal in T1 and 4. Is cortical too, and there's some extension to anterior to a parietal occipital area. Can we see the next one?
Yes.
Yeah, you see that is not an only occipital lesion. You can see an extension of this alteration of signal of the Y matter to the parietal and temporal, and probably you can see the hippocampus area in the center area in 4. And there are not abnormal enhancement in this imaging. Look like a large malformation, abnormal developmental malformation, and is extend to the occipital, temporal medial, and parietal medial area. That's all.
So we decided to practice on PET-CT. So Dr. David, could you explain?
Okay. Well, we have here a very abnormal PET-CT scan. Maybe we have 3 kind of alteration. The first is the very hypointensive and MRI is a lesion with no uptake of EEG in the center of the occipital lesion. There is no life in this center lesion. We have the second type of uptake is the red one, very hot, is a very high uptake of FDG surrounding the central lesion, and a third lesion of pattern is the rest of temporal, occipital-temporal territory with very low uptake of FDG. Maybe this can be explained by a very active AAG during the PET. I talking about the red lesion, the hot lesion surrounding the malformation, and we have to see the AAG during the PET to can interpret better way this hot ring, and in the metabolic territory and temporal cortex is maybe a mix between functional deficit zone and lesion zone, and visible in MRI.
So
this yes, this is the summatory projection of the same, and we can see a better way the hot lesion, the very hypermetabolic ring, and the extensive hypometabolic cortex in a temporal and parietal and occipital territory in the same left side.
okay.
Okay.
So, Dr. Gaillard, we have some questions for you. The first one, what would you do in this case? Remember the question of parents of this patient, and the age, and no hemiparesis, and whatever. And how do you interpret it, ictal PCT in this case? Because remember, she had about 50 seizures during PCT, and how useful can be an ictal PCT? We would like you to tell us.
Certainly. So I would send them to you. So I do have a question. Does she have a visual field cut?
She has a moderate intellectual disability, so it was very difficult to practice functional MRI or visual field study.
I mean, I would find it hard to imagine that she doesn't already have some visual impairment out of that hemisphere, given how abnormal that tissue is.
Yeah. So.
I just asked the question because, so this is a lady who's had lifelong seizures. I think there may be some communication issues about the early seizures, because it seems to me that everything comes from the left hemisphere in the occipital lobe. She's got an abnormal MRI. She's got an EEG that's concordant with that. So her seizures come from her left posterior quadrant. With this nystagmus, they come from the occipital cortex and adjacent parietal cortex. And with that, you have enough information to operate. If I just had the MRI, you can't escape, if you wish to cure her from her seizures, you cannot escape affecting her visual fields if they are intact or partially preserved. On the other hand, her seizures are going to kill her, and I don't think a field cut is going to significantly impact on her life, and you have the chance of making her seizure free. So I don't think you can proceed. I mean, I think whatever you do, there's going to be, or there may be some change in her visual fields if they're not already impaired. and you can't escape that. In an earlier time, I would have just done the resection up to the sensory cortex and take out the temporal lobe, the parietal lobe, and the occipital lobe. I think the ictal PET actually is very intriguing because that suggests that really, while she's got lots of funny brain tissue in her temporal and parietal cortex, what's causing her troubles are likely coming from around that lesion in her occipital pole. I would interpret the increased FTG uptake as being an ictal or post-ictal effect of her numerous and ongoing seizures, only some of which you see with your surface EEG. And that may mean you may be able to get away with just taking out the occipital lobe and not even having to come close to her parietal cortex or her sensory motor cortex. As the Miami group and one or two other groups have reported, when you see increased uptake on PET, that correlates with an abnormal tissue, which you have on MRI. And when you stick electrodes in the cortex, it's electrically seizing. So I would interpret the CT, the PET CT with its increased uptake as being really remarkable. And that would suggest that area is constantly seizing. So you may be able to get away with a more limited resection, knowing that she has the risk of recurrent seizures from the residual dysplastic cortex, and she may need a larger resection going down along the line.
Mm-hmm. Okay, thank you. So,
so what did he do?
Yes, the opposite now, something very similar. So, what is the problem? Sorry, Javier, tenemos un problema con la imagen. So, surgery was on my 2019. Our team decided resection of PET-CT ictal active zone corresponding with echo-copper suppression pattern. So it was a left occipital and posterior aspect of occipital lobe, avoiding visual field sequela with posterior corpus calliosotomy. Post-surgery follow-up, she is seizure-free, or she was seizure-free for 1 year. Then she is suffering for about one very brief and light seizure per month with nystagmus, ED with occasional interictal epileptiform activity, no seizures, but still on AS medication. So this is our first case. This is the post-surgery image. I don't know, Dr. Marcelo, do you want to say something?
Yeah, you can see here that we resect all the dark area, but this extension to parietal. But we don't touch this alteration in the hippocampus. And it's very interesting because the follow-up say that this decrease in size. But probably this is a mixture between an alteration of the cortical development and a functional alteration during the seizures. We are very clear that probably this is a partial result of the resection, but probably we have a windows in time for a free seizure patient. But in any moment we'll start the seizures.
Thank you.
That's a great case.
Yes, a great case and a great team. This is Dr. Solari, the real treatment of this patient. Our team, surgery team, Dr. Campos, Dr. Falacher, and our radiologist team too. And then I'm going to present our other case. It's about tuberous sclerosis complex. Yes, I know you talked about this, but we want to.
Yeah, they're tough.
Yes, it's a very difficult topic. Sorry, I'm going to put in presentation. Wait.
Mm.
So she's 16-month-old girl with tuberous sclerosis complex, TSS2 mutation, with refractory epilepsy began at neonatal period, with seizure semiology with bilateral fast eyelid fluttering, impaired awareness, no postictal, generalized tonic posturing, and impaired awareness. Age up 10 per day seizures. With current treatment, carbamazepine, and a lot of other treatment failed. This is her ictal electrocephalogram with an electroclinical seizure. Focal from left posterior theta rhythmic wave with impaired awareness, behavior arrest, bilateral eyelid fluttering. Neuroimagens, maybe Dr. Galvez?
Yeah, we have an axial imaging. You see that is a normal polymyelination, but there are a lot of a dark lesion, subcortical lesion, in the principally in the temporal occipital area. Put the next one, please.
Sorry.
Yeah, and this is in T2 in axial imaging and coronal. You see that this dark cortical and subcortical area, principal temporal and occipital, and probably it's not easy to see. Probably there are another that is invisible, but in coronal you see these very clear lesions and very related to the EEG alteration.
So Dr. Ladrón de Guevara.
Okay. We see a patient with a lot of tumors here in both hemispheres. And normally the tumors have very, very low uptake of FDG. But in this case, we see a extensive area with moderate decrease in uptake in parieto-occipital cortex in left. And then this tissue with lower uptake lies between tubers, between a lot of little tubers, and there is no, you see, there's no a hot tuber here. We have a tissue with lower uptake than normal, but not like a tuber, like the frontal anterior left is a tuber with no very, very, very low uptake in the frontal left and in the middle image, Francisca. Can you show in the frontal cortex in the left? We have a tuber with very, very low uptake. Can you show this? No? Okay. Okay. Well, we don't have a hot tuber here. We have a pretty extensive tissue with decrease with low uptake, abnormal low uptake, but I think it's tissue between tubers in the occipital and parietal left cortex. And the next, there is next? I don't know. No, okay.
In summary, an 18-month-old TSC2 mutation, refractory epilepsy, left posterior focal stereotypied seizures, MRI with multiple tubers, PET-CT with left temporal parietal occipital cortical hypometabolic area. So we decided surgery with a focal resection of that large left-grouped occipito-temporoparietal tubers. And in the follow-up, she had a focal motor seizure during immediate post-op, about 10 hours. And now she's seizure-free, up to date. The surgery was recently, it was about 20 days ago. And her EEG, neither intellectual epileptic activity nor seizures. So our question is, how do you study? You talked about this, but how do you study presagial patient with TSC? And what PET-CT tubers characteristic do you consider as suggestive of active or epileptogenic tuber?
Yeah, so I think this is really a great case, and you did really, really well by this child. The TS kids are really, really hard. I think, you know, if the children with later onset focal epilepsy do better with surgery than the younger kids, and trying to find the epileptogenic tuber is really difficult, and often the earliest EEG is the most helpful for you. Trying to find that tuber is, there are no good data for that. That's why I find, you know, Ellen Grant's description of the tubers from an imaging point of view to be curious. And the Lyon group just published their series on providing evidence that may support that observation of the type C tubers. FDG PET has not been helpful in this group. Harry Chigani used FDG PET for years, and it never helped him. So the tubers can be, they're generally hypometabolic, but they may be isometabolic with the cortex. They very, very rarely are hypermetabolic. So they don't really help you, I don't think, in determining where to go after. They may identify tubers you don't see on MRI because of hypometabolism, but they don't really help direct treatment. Some people have tried to use diffusivity metrics around the tuber, what the UCLA group has done, but no one's picked up on that. The Toronto group uses MEG. We use Curie. That may be helpful in identifying clusters of dipoles that harbor around one tuber. That may be helpful for you. Alpha-methyltryptophan PET was advocated by Dr. Chigani, but that ligand is not FDA approved and it's not available for common use. So what we've taken to doing is to do stereo EEG on these children where we have a quadrant and multiple tubers. In the past, we would do what you did, which was to take out all of them after doing some corticography or grids. Now we're inclined to put depth electrodes in the tubers to try and find out which one is, or which ones are talking to each other. They often talk to each other and get each other excited. So we have used stereo EEG, which you can do in young children, but once you get below 2, it's really difficult because of their skulls and sticking wires through them. And that has helped us identify some tubers and plan surgery. The other thing has been good for is that if the tuber is small or is not irregularly formed, we have then used laser ablation to burn out the tuber because the pathology is not in question. I've been very reluctant to use laser ablation therapy when I don't know what the pathology is, but with TS, that's not a surprise. So after the stereo EEG, we often have ablated the tuber with stereo EEG, and we occasionally get away with it. But these kids are really, really hard, and I think you've done a really great job with this particular child.
Yeah. Okay. So okay, it was very difficult case. So thank you, Dr. Gaia. Now Felipe is going to ask you some questions from the audience.
Muchas gracias, doctora López. Ahora procederemos con el ciclo de preguntas y respuestas. La primera pregunta para el doctor Aguilar es en relación al uso de panel genético en pacientes con displasia cortical focal. ya que sabemos que muchas veces la mutación es solamente encontrada en el tejido cerebral somático y no en la sangre periférica, desde donde obtenemos la muestra. The first question for you, Dr. Blar, it's regarding genetic panel in patients with FCD. Is it worth performing? As you know, many times the mutation is only found in somatic brain tissue rather than peripheral blood, which is usually something you get. So do you suggest performing even so?
Sorry, so the question is genetic testing for the dysplasia that's resected?
That's correct, yeah.
Or genetic testing in anyone with a dysplasia from their blood?
It's worth requesting.
Yeah, so,
Well,
I mean, there are mutations like the TSC and DEP5 that are associated with second hit mutations in dysplasia. So that may give you the pathology, but it doesn't mean you're not going to operate on a child, because even though they may have a general mutation that predisposes them to dysplasia, you can still remove the dysplasia and be successful. I think the issue of how dysplasias come to be is really a fascinating one. And most of us were brought up looking at images and looking at pathology and trying to identify if it's type 1 or type 2. But we have ignored the revolution that's occurred in pediatric brain tumors. And it's the genetics that matters rather than what the things look like under the slide. So I think the somatic mutation that is responsible for the the migration and the dysplasia that ensues is likely more relevant to the pathophysiology of the epilepsy than what the tissue looks like. And I think we're just beginning that journey to understand that. And that may also be able to map out the adjacent areas that you have to go after surgically. But it's not common practice to do that. We work very closely with someone whose name is Judy Liu, who used to be with us. She's now at Brown. And she looks at all our surgical specimens. She's identified a clock gene, which may be a common mediator for dysplasias, but she's also identified or excluded a bunch of somatic mutations. And we now have a collaborative project with Joe Gleason at UC San Diego, again, to look at somatic mutations and their pathophysiology. I think Jim Barkovich at UCSF has done really a terrific job of identifying, based on imaging abnormalities, what the mutation is likely to be. But I think there's a whole new world to be understood by looking at, in a more detailed way, at the genetics of the dysplasias. But it doesn't change what I do right now.
Gracias. Thanks. Okay. La segunda pregunta se relaciona al fenómeno de la hipermielinización, que en ocasiones vemos en el contexto de algunas malformaciones del desarrollo cortical, como por ejemplo la meganencefalia. ¿Cómo se interpreta? ¿Se sugiere seguir en el tiempo mediante resonancia magnética? ¿Se puede ir a la cirugía en una primera instancia? The second question is regarding hypermyelination phenomenon. How do you interpret that? What do you do when you see an infant with a hypermyelination area? Do you suggest follow-up? Do you repeat the MRI over time? Do you proceed to surgery even in young infants?
I'm sorry, I missed the transition from the Spanish to the English. When you see
Okay.
When you see
Hypermyelination.
Hyper or hypomyelination?
Hypermyelination. How do you interpret that phenomenon? The question is, do you suggest?
I asked Gilbert what to do. Yeah, it's the white matter is like the ocean or the desert. Everyone ignores it, but there's a lot of stuff to be learned from it. And I really don't know what hypermyelination means right now. I mean, presumably it means that there's a bunch of tight neurons that are leaving that area that may be mischievous. I think hypomyelination is more likely to be seen, and that may or may not be associated with a dysplasia, as we find in temporal tip, what we call temporal tip dysplasias, but may just be myelination disorders. So I like encephalomalacia, I take that with a lot of skepticism. I follow those kids as closely as I can, but I don't think that that provides a prognosis the way that a clear cortical lesion provides a prognosis for a child. Unless it's it's an obvious pattern for leukodystrophy like adrenal leukodystrophy, then it's a separate issue. But if it's nondescript, it can't be linked to a syndrome. I don't quite know what to do with it, and that really doesn't direct. I don't think that has a correlation with where the seizures come from and what to do. Your experience may be different, and if so, I would be more than happy to learn from your experience.
Gracias. Ok. Recientemente discutimos un paciente que tiene una imagen positiva en la resonancia magnética, una displasia cortical focal, pero con un PET negativo, y teóricamente este PET fue interictal. ¿Ya? The question, Dr. Gillard, is regarding a patient we have just discussed with FCD MRI positive, but the PET-CT was negative, so no hypermetabolism, and supposedly this was an interictal PET. So how do you interpret this discordance between positive MRI and negative PET?
Right. So again, I think not everything has to line up. If you got a lesion and it goes along with the seizures, then the lesion comes out. And to me, it doesn't matter what the PET shows or what the ictal SPECT shows. The issue is if the lesion doesn't make sense from what the child's clinical seizures are or what the EG is, because then there are rare cases, really rare cases, where the lesion is not it. But for most children, in most cases, if you have a clear lesion, that's the source of the seizures, and you have to disprove it. So, PETs are a snapshot in time of 10 minutes worth of metabolic activity. So a dysplastic tissue can be hypometabolic, it can be normal metabolic, or it can be hypermetabolic. And as you will know with PET, one reason why one does EEGs with PET scans is you want to assure that it's an interictal study, because if you have a seizure, then you may get false lateralization because you interpret the other side of being hypometabolic. You may get false normalization of the area because the ictus generates increased metabolic uptake, and so the pattern normalizes when in an interictal state it would be hypermetabolic. Or it may be hypermetabolic because you caught the seizure and you were lucky. So, to me, there are many possible explanations for why the lesion may be normal metabolic, but that doesn't mean the tissue is not electrically abnormal at other times. So I would go after the lesion. I do believe very firmly in what Mike Duchani and Prasanna Jayakar have always said, and that is, you got to really listen to the patient and what the first symptom is with their seizure, because if that doesn't go along with what you see, then there's something wrong. But if it goes along, then you're in the right place and you can proceed.
Y la pregunta final, usted acaba de decir que entre mayor el hipometabolismo visto en el PET, el pronóstico teóricamente era mejor. ¿Cómo se explica eso? You have just said that the greater the hypometabolism seen on the PET-CT, the better the outcome. How do you explain that?
I'm sorry, how does the abnormality impact the outcome?
No, it's rather, you have just said that the greater the hypometabolism seen on the PET-CT, the better the outcome.
Excuse me, my daughter is behind me because she wants to join you in Chile.
How do you explain that? The greater the hypometabolism seen on the PET-CT, the better the outcome.
I think this is a relative finding. I think the more abnormal the study is, the more likely there is to be significant pathology in that area. So if you really are profoundly hypometabolic, then the neurons there are really dysfunctional and likely to be very abnormal. When the findings are more subtle, that is less clear. But the caveat to that is the last PET image I show, which a profoundly hypometabolic abnormality in a child who got a genetic epilepsy. So I don't think that holds in all cases. I think it tends to reflect, and maybe that child has dual pathology because we never operated on the child. But I do think it tends to reflect the severity of the pathology that likely underlies that finding. And the more severe the pathology, the more focal it's likely to be, and the more likely you are to be successful when you remove it. And I think the same is true for hypermetabolism, because I think that reflects abnormal activity of brain cells in that area, and that's a dysplasia, as you showed in your first case very elegantly, that can be resected and lead to success. And also, if the MRI, if the PET scan is really hypometabolic with the CT scan, and you look at the MRI, then you're more likely to find, I think, an abnormal tissue in that area. I would say, you know, the other exception to that is if you look at all the kids with tuberous sclerosis who have really profound hypometabolic tubers, you know, they're just dead tissue. They're not doing anything. They're not seizing. They're just dysfunctional. So there's another example where profound hypometabolism doesn't really predict where the difficulty may be. So I may have to change that statement.
Bien, ya estamos en la hora. Quisiéramos agradecerle a todos los asistentes de hoy por su participación y, en forma más importante, al doctor Aguilar por todo su tiempo y su excelente disposición. Finalmente, quisiéramos dejarlos invitados a nuestro próximo webinar, que será realizado el día 14 de julio a las 19 horas con la clase El uso de CBD en epilepsia, la que será presentado por el doctor Roberto Caraballo. Que tengan una muy buenas tardes y nos vemos. Well, yeah. Anything further? We're done, Dr.
Thanks a lot.
Dr. Pilar, can you hear me? I think he's offline now.
William?
Okay. Hello. Well, we would like to thank you again, Dr. Pilar, for your brilliant presentation and your readiness and all your time. We know you are on call now, so you're covering the whole ward, so we really appreciate your excellent.
But my daughter has been carrying, my
to-
daughter, who's a medical student, has been carrying my beeper and my cell phone, and she is taking care of all the hospital emergencies. And I have been free. I would much rather chat with you than read EEGs in my office. So it's been a great pleasure for me to join you today. And again, hopefully one day we'll be able to meet in person. And if there are any other questions, I'm more than happy to answer them, and people should be free to have my email address.
Yeah, of course.
Thanks a lot.
We'll be looking forward to receiving you. So please, you're welcome. Okay.
Very much.
Bye. Bye.
Thank you
Take
very
care.
much.
Thank you very
Bye-bye.
much. Bye.